Okay, awesome. So, hello everyone, and welcome to another one of the American Physician Scientists Association's interactive sessions. Tonight, we're really excited to host a conversation centered around clinical informatics, featuring insights and advice directly from Clinical Informatics Graduate Fellowship Program Directors. My name is Alexis Shintelm, and I'm one of your moderators tonight. I'm a third-year MD PhD student. Helping me behind the scenes are Nick Pasternak, an MD PhD student in his final year, who will be managing the chat, and Jonathan Sanchez, who's a third-year PhD student who's live tweeting highlights from our conversation. This session is designed to be informal and interactive, so we highly encourage you to participate, ask questions, and learn from our amazing panelists who have graciously joined us to share their journeys and lessons learned in the field. Joining us today are Dr. Joseph Canry, a professor of medicine and pathology and program director of the Clinical Informatics Fellowship Program at Mount Sinai Health System, Dr. Saif Khairat, a Bierstecker-Blackwell Distinguished Professor and Associate Director of the Carolina Health Informatics Program at the University of North Carolina, and Dr. Raman Khanna, a Professor of Clinical Medicine and Program Director of the Clinical Informatics Fellowship Program at the University of California, San Francisco. Here's a brief overview for our webinar today. As you can see, there's a Q&A at the end of the session. Please feel free to submit your questions in the chat or the Q&A box throughout the session. We'll also be pulling questions from those submitted during registration. That's all from me for now. So thank you again for being here tonight. I will let the panelists take over now for their own presentation.
All right. Well, thank you so much for that very generous introduction, Alexis, and thank you to APSA for having us at this webinar. We're very excited to talk to you about informatics and about informatics fellowships and informatics training opportunities and how folks such as yourselves can get involved in this very exciting field. So I'll be speaking first. I'll be talking about clinical informatics and the fellowships in particular. And I see biomedical informatics as referenced as something we should talk about. Maybe we can do that in the Q&A and what the differences might be between biomedical and clinical informatics. But anyway, I'll come back to that. So what is clinical informatics? There are many definitions out there about clinical informatics, but the one that's my personal favorite, that I think actually Joseph might have shared with me at one point, is this one, which is that if a doctor plus a computer is better than the doctor alone, and it's not doctor specific, it could be a nurse, it could be a physical therapist, it could be a pharmacist, it could even be the patient advocating for themselves. And if there is this proposition that they would be better with the computer than they are by themselves, it is the job of the informaticist to make this equation true. And I know that many of you are students, many of you are still in the PhD phase of your training. You may have interacted a little bit with the electronic health record and with other digital tools. But let me just tell you that there are many, many instances where this equation is flat out false. The computer slows things down. It relies a lot on people putting data in. It creates all sorts of problems for the clinician. There's data that gets in there that's wrong and then lives forever in the chart. And so it is the job of the informaticist to really do the best that they can to make this equation true and steer the cooperation between the clinical system and the computer system to the areas where there is good overlap and steer it away from the areas where it's no good. And so a slightly more I don't want to say dull, but a slightly more standard definition of informatics is that it's clinical professionals who analyze, design, implement, and evaluate information and communication systems. And just to be clear, we are not scientists or clinicians tinkering with computers. That is not the job here. The job is really to try to find ways to make things better for our patients and for our clinicians. And so who is a clinical informaticist? Who is somebody who does this kind of work? It's a clinician, and I put a star here because you're a group of physician scientists. So for you, you would be a physician with expertise in both medicine and informatics. And kind of like one of the most easy way to think about this is you speak doctor to doctor and you speak IT to IT. You are able to translate from one to the other so that if someone says, I can't seem to order this thing that I really need to order, you can then translate that to the informatics team and to the IT team to say, look, this orderable doesn't exist yet in our electronic health record, and these are the parameters that are needed so that they can specify what they need and get what they want. And then it just is important to note that effective digital workflows don't just materialize. Like, you really need someone who is pounding the pavement and really working with everyone that's going to be impacted by the workflow. And I'll try to give like a small example of that in a story in the next slide. It is a highly collaborative field. You will constantly be working with people. I would say like 90% of informatics is actually the people. Only 10% is actually about the technology, because a lot of your time is going to be spent talking to people about how do we implement this safely? Are there considerations around regulation? Are there new technologies coming that we need to be aware of? How do we future-proof this? Blah, blah, blah. So you can imagine there's a lot to do and a lot to think about and a lot to talk to people about. It has a lot of non-procedural appeal. So if you're really into internal medicine or neurology, there is a huge component of just spot the lesion. Like, if something goes wrong with the system, then the non-procedural portion of this is you have to sit down and figure out, well, why is this working and this not working? Why is this part of the flow impacted but not this workflow? So you can figure out where things have gone wrong and how to troubleshoot them. There's also a certain procedural appeal to informatics because you often have to just turn things on, and you've planned the best that you can, but at some point you just have to do that procedure of turning the application on and seeing what happens. And everything runs through informatics these days. Like, no matter what new therapies exist, no matter what new laboratories are out there, everything that people can think of to do will eventually have to be done through the electronic health record. And so it is the job of the informaticist to help facilitate all of that. And I would say, like, clinical informatics bears a lot of similarities to research. You're spending a lot of your time meeting with people, scheduling things, figuring out how to make progress on these various projects, often with very, very open ends, sometimes with no set deadline, sometimes obviously with deadlines. But it does have some important differences. It's usually independent of NIH funding unless you're formally also a researcher. It is dependent on the priorities of the enterprise that you're in. And there are many opportunities to innovate, publish, and improve the lives of your colleagues, but your sphere of influence tends to be faster and smaller than it is with research. So it's not so much about the generalizable knowledge, and it's more about, like, how can you make things better for the person that's sitting next to you. So the story that I was mentioning about is that here's just one example, is that it used to be the case that physicians and providers of other types would write prescriptions on paper, and we would then give it to the patient, and the patient would take it with them to the pharmacy and get the medicine filled. And that was a pretty reasonable way of doing things, but it did have the downside that, for example, then the patient is waiting at the pharmacy. The patient can't get some of these meds because the pharmacy doesn't stock them. Some of these things you really want to know in advance. And so an implementation of EPCS, which is to say the electronic prescribing of substances, and in this case, controlled substances, was really, really important because it could help to identify some of these issues in advance. So, but to do that, you needed someone who had that informatics experience. And so when an informaticist sits down to do this kind of project, they say, okay, well, who's placing the order? Where does it have to go? Is there already a connection between those two computer systems? How can we ensure that it goes correctly? How can we ensure that the person who's placing the order is placing it on the patient they think they're placing it on, and also that no one has swiped their credentials, especially when you're talking about controlled substances that are very lucrative in the streets, while having like really important clinical uses. And so it is just one example of where, when informaticists got involved and did this project, the costs were substantial to actually sit down and have all these meetings, map out all these things, stand up all of the connections, ensure there was a good security process in place. But one of my colleagues, Dr. Bruce Levy, points out that even though there were costs like in the several $100,000 range, the savings to the institution that he was involved with were over $1 million. So that is like a really concrete way in which informaticists can really make life better for a lot of people. So the CI Fellowship is how you become a clinical informaticist. And so the CI fellow is doing a 2-year ACGME fellowship. Many of you probably know this and have thought about what you want to do when you finish your medical school component of your studies. But after you do your medical school, you'll do a residency of some sort. And after the residency is when you do the ACGME fellowship in clinical informatics. And the goal of it is to become a clinical informatician. There is a board exam at the end of all of this, and all kinds of physicians matriculate into this field: primary care, inpatient, pediatric, adult, OB. There's generalists, there's specialists. We really see like a very broad range, and that's important because everyone is affected by the electronic health record and all of the associated digital health tools that are out there. And the training itself includes, but isn't limited to, clinical decision support, health information technology safety, quality improvement. Artificial intelligence obviously has absolutely exploded. I'm sure many of you are using it in your own work now. And there are all sorts of discussions underway about how to use it in the work that we do in taking care of our patients as well. There's also run-of-the-mill optimizations that we have to do on our electronic health record. There's remote patient monitoring, telehealth, population health, change management. Change management, of course, is just like getting people to agree that this is a good thing to do and or to do it anyway, even if they don't love it, because it has to be done for other reasons. And then being able to have leadership in the learning health system as well. And so the clinical informatics fellow knows how to do all these things. They don't necessarily know all of these very, very well, but they are able to teach themselves a lot of this and how to do it. And there is, I'm not going to go into the details of all of this, but decision support, monitoring and analyzing data, implementing and optimizing the electronic health record itself, figuring out who all to talk to, and in making sure that physician order entry works the way it should, being aware of the EHR's role in burnout and thinking of ways to address it, moving new forms of data into clinical workflow. And, I would be remiss if I didn't again mention artificial intelligence as an absolutely enormous part of this, because there's so much that's coming down the pike in that space, from ambient scribing to discharge summarizations to just, so many different like reports that are being summarized and sort of aggregated. And so it really takes an informaticist to understand where in the workflow all these things fit and how to make them happen. The clinical informatics fellow is often in the room where it happens when decisions are made about projects to go live, why certain things were considered, why certain things were discussed. And the informatics fellows are often connected to one another nationally in a way that even their attendings are not. So you may find, if you do this fellowship, that you're asking people at other institutions, hey, how did you do this? How did you do that? And getting answers quickly and in a very friendly way that's sometimes not even accessible to people such as myself, like who are far out from training. And one of the key things is that, we say in informatics, there's nothing new under the sun. Almost every problem that you deal with is a problem that someone else has dealt with. And unfortunately, that doesn't mean that we don't make the same mistakes as other groups, but this is actually one of the real values of the informatics fellowship. I'm going to skip over this slide, but just to give you a sense that the physician informaticist does a lot of different things. CI fellowship is not about being a techie per se. I mean, being technically versed and knowing what things mean and how to sort of work on them and who to talk to when things break down is important. But you're not going to be the one writing the code, and you're not going to be the one sort of like servicing the servers and the server racks that are out there. But you will have the ability to understand when things go wrong, like who to talk to help make things better. You'll interface with analysts and programmers. You'll recenter the conversation around clinical workflows. You'll make IT decision-making understandable to clinicians, because sometimes clinicians are like, why did you implement this thing? Why did you do this? Why did you do that? And sometimes it just takes somebody who's also in their shoes to explain that. And it increases the effectiveness of everyone on the team when there's an informatics fellow around and an informaticist generally. So this is an old slide, but I kept it in because the idea used to be that you could just come up with a way to do informatics just by working on it. And there was a pathway to do this kind of thing that involved, practicing at least 25% of the time for 3 years in informatics, and then you could take the board exam. But one of the things we realized is that the fellowship pathway is really, really superior to this in terms of the amount of hours and the quality of the hours that you get. So you're spending dedicated time, much as many of you are in your PhD programs, to really understand clinical informatics. And that time is 2 years, and it's about 80% of your time. So that's 3,200 hours versus the 1,500 hours you would get out of the practice pathway. And so that's a real difference, and one that we believe is meaningful and important. So even like whether or not it allowed you to be eligible for the boards, there's just clearly no contest between these two. So again, why do a CI fellowship? Like, one of the questions that you ask yourself is, well, why would I do this extra 2 years? Well, it really opens up your freedom to do interesting and exciting work. It opens up your opportunity to affect whole systems in addition to your individual patients. There's often a salary bump in many of the specialties, especially if you end up in the CMIO, that's the Chief Medical Information Officer track. And I just want to highlight that in one recent survey that was done, a lot of the fellows who completed the fellowship were able to stay local, like in the same region as where they trained, which is important to many. 80% had a position that was essentially created to them. Now, granted, there's some response bias, and I'm sure many of you are very skeptical looking at survey data, being PhDs, but nonetheless, I think it's important to share. 80% felt like they would not have gotten their current position without the CI fellowship. And I think one of the most important statistics is that 80%, 79% are very satisfied or satisfied with their jobs. And I will tell you, in medicine right now, that is not common. There are many, many specialties where people are really burned out. And I think one of the nice things about CI is that you can feel like you're going to be a part of the solution to that. So I will stop there, but I did want to at least put in a plug that the CI fellows themselves are their own best advocates and often their own best selling point. You can take a look at this particular link, and you can see like some of the work that they've done and some of the projects they've worked on. And I will stop there and turn it over.
Thank you. I believe Dr. Canry is going to be speaking next.
Okay, let me share my screen 1 second. I wanted to show. Good, okay, probably more project. So I'm going to give a similar talk, which I think will both add and reinforce what Roman said. And I want to first talk about where clinical informatics fits in. It fits into the broader field of biomedical informatics. It's health science, information computer science, management science, decision data science. These are the broader things in the broader field. There are multiple education pathways in biomedical informatics. There's AMIA tutorials, and there are continuing education materials, and AMIA, American Medical Informatics Association, is doing a lot to provide new educational materials. There's 10 by 10 AMIA certification, which is you can take a course, get a certification. It's usually about $2,000 a course. AHIC, which is Advanced Health Informatics Certification, which tends to be for physicians who can't get board certified, but it can be for any health professional with health experience. Fellowships, there's the NLM Research Fellowships. If you're not going to practice and not going to do a residency and just graduate med school or just have a degree, that's where you should be going. If we'll talk about a minute, clinical informatics fellowships, and there are masters and PhD in biomedical informatics. AMIA is a community of physicians, nurses, pharmacists, dentists, academicians, data scientists, public health specialists, engineers, etc. We all want to improve healthcare through the application of informatics. It's an evidence-based group. It's data-driven. It's not just physicians kind of mucking around with computers. These are the different ways you could follow AMIA. They have student memberships. This is how informatics fits in the broader scheme of biomedical informatics. It's one area. It's not the whole field. It's in the applied operational end of things, which means it can do research, but that's not its focus. This is what clinical informatics is, the intersection of clinical care, health system, information, and communication technology. This is not what informatics is, which is it's not just docs and computers. One of the really common misconceptions is that you put a doc in a computer and you have an informaticist. That's not the case. Sorry, it does this from time to time. As Roman mentioned, it's an ACGME accredited American College of Graduate Medical Education with boards in and upon completion. It's a 2-year fellowship. ACGME makes very strict what we can and can't do in terms of training, rules, etc. Informatics is considered a subspecialty to all specialties. So that means you have to have completed residency training and be board eligible, board in a specialty. If that doesn't apply to you, I recommend one of the other educational pathways. It can be combined with existing medical subspecialty training. So you could do, a combination of, let's say, oncology and informatics and maybe combine it so that there's 1 year less of training. Our match is usually the December before the July, so this year is December 2025 through July 2026. So what do you need to be a fellow? Do you need to be a programmer, a geek, tech head, the IT guy, an engineering graduate? Actually, no. You need 2 requirements. You want to transform healthcare through the use, management, and application of information technology, and you're willing to learn. At the Mount Sinai Health System, the focus is on optimizing information use of all clinical information systems, work on implementing, optimizing, and maintaining EHRs, hardware, software, data, workflows, people. Now, this is a key point. It gets back to the residency requirement, meaning residency training. Independent clinical practice is 20% of fellowship, which means if you finished a residency in internal medicine, pediatrics, you can go practice. We're allowed to count it towards fellowship time, but we have no supervision or training. You're not doing clinical training under our supervision. You can work clinically. Working clinically ensures we have insight into workflow and day-to-day practices. Why is it important to healthcare organizations? Quality safety, reduces costs, improves efficiency, decreases provider burnout, helps with evidence-based decision-making, promotes patient engagement and satisfaction. These are the areas our boards cover. I'm not going to go into the percentages, but I want to give you a flavor of what we're tested on. So, are fellows practitioners, scientists, or a little of both? Think of the model of training from med school to residency to fellowship. You're trained in the science. You're taught how to apply the science to practice. You get experience in practice. Some of you will go on to be scientists, some will be practitioners, some a little bit of both. All will have this body of knowledge, know how to get more, and know how to apply it appropriately. These are examples of fellow projects at Mount Sinai. These are some of the publications our fellows have done. We insist they're scholarly, not just operational as well. These are some of their poster presentations. Now, life after fellowship, the career a survey was done, and I think Rumman referred to the same survey, 1 to 6 years out of fellowship, 242 graduates from 2016 to 22 responded to a voluntary survey, greater than 50%, which is an amazing survey response rate. Most reported CI fellowships significantly impacted their career or satisfied with their first and current job after training. I think that's the most important thing. And that's all I've got, and I'll turn it over to the next speaker.
Great. Thank you so much, Dr. Cannery. You're welcome to share your screen, and you are awesome, Dr. Carrot. So whenever you'd like to start, thank you.
Thank you, and good evening, everyone. Welcome to this exciting panel. So, building on the information shared in the previous two talks, I'm going to speak more about the education and certification opportunities that are within the clinical informatics field, and maybe focus more on the premier body or organization, AMIA, the American Medical Informatics Association. So, AMIA, which serves as a hub really for most of the informaticians in the US. It converges research, education, mentorship, as well as other opportunities. The nice thing about AMIA, and I've been involved with AMIA, like my colleagues, for a while, is it offers a diverse set of educational opportunities. Whether you're still in training and trying to learn more about the field and what's out there, and understand or do a survey of the landscape to understand what is, hot areas in informatics or career pathways, it really provides, from an entry level all the way to mid-career and beyond, opportunities to learn and improve and continue to do professional education and development, which is one thing that I really like about AMIA. And wherever you are in your journey, you're going to find a place for you within the association. So the previous speaker mentioned before that, the virtual 10 by 10 courses, very famous signature AMIA education product. It's basically a short, think of it like a crash course, a few months of introduction to informatics. And what does informatics mean? What does it not mean? How could you tie your interest into the ongoing body of work? So it's really a nice entry level introduction to the field. Also, AMIA offers other types of hands-on experiences or training. It also offers certification. So once you graduate and you're in your residency and complete your residency, you could also start looking at clinical informatics fellowship opportunities. The other thing that AMIA recently produced, and I was a chair of the education committee that led this work, was the AMIA AHEC, Health Informatics Certification, which is geared for non-MDs. So that's a different course, but the thing here to keep in mind is there is both education for physician and physician scientists, but also for non-MDs, there's also that opportunity. This, AMIA has been involved with training and certification for a number of years. Most relevant to this conversation is the two pathways. You could go through the American Board of Preventive Medicine, ABPM, or the American Board of Pathology, ABPath. And these are the two ways that you can get certified as a clinical informatician or a clinical informaticist. This is from AMIA education office, and you can see here the number of individuals for the past over a decade, really, who have been, we call them clinical informatics diplomats. And these are people who earned their certification, board certified in clinical informatics. And you see that there's a huge influx in the beginning when it was first introduced, and that's mainly because there were lots of people who wanted to apply for it, who did not have it. And then it's steadily increasing over the years, where we have the majority of people or diplomats are through the ABPM process. They're also a good minority through the pathology route. AHEC, which I just mentioned, this is just for your information for the non-MD's track. Not going to dive too deep into it, but basically this offers a certification process for nurses, pharmacists, and other health professionals to be certified in health informatics. It has a requirement where you have to have a master's degree in an accredited institution that offers a health informatics education. So it has some specific eligibility criteria, but it's an exam that these people take, and then once they pass, they receive the AHEC badge and they become certified. So for the sake of this conversation, you may be interested in learning more about informatics, but you probably are bombarded with lots of readings and assignments and um, clinical rotations at some point. So there are a few different options. There's the 10 by 10 course, which is, you could do it up to 3 months. And the most famous one, I think, is by our colleague, Dr. Bill Hirsch from OHSU. It's been ongoing for a number of years and basically introduces students into areas very diverse. Now AI, of course, but clinical decision support, nursing informatics, public health informatics, consumer health informatics, and others. So it gives a good taste of what's out there in the field without diving too deep into it. If you're interested in doing more in depth, then through AMIA, there's the academic forum that has representatives of academic programs across the country. They offer master's and PhD programs in informatics, and they are usually accredited by CAHIM. And then after you're done with your training and you're ready to pursue the next step, you start looking at clinical informatics fellowships. And the last here box here, step 4, something for you to know if you're interested in participating and joining one of our AMIA meetings. There is the LEAD Fund, which is a scholarship to help people who are interested in the field to join us, attend the meeting. It offers a stipend for accommodation and maybe travel. But it's a really nice resource that AMIA provides for trainees and emerging professionals to come and learn more about about what's happening in the field. My experience very quickly is that there's a ton of opportunities at AMIA. Really, it's and these are some of the things I've done over the years. I've participated in working groups. There's, I think, 20 or 25 of them. You participate in working groups. You could also help write or revise some of the questions for the prep course for the board that AMIA does. So I was actually a writer at one of the years, writing questions and answers. It was a lot of fun, learned a lot. And you can also participate. You can be a student volunteer for some of the meetings. You could participate in scientific program planning and development, participate in other educational related activities. There's a ton, and there's always room for collaboration and opportunities. So I encourage you, if you're interested, to start early. I started in my early days in my master's, and it was a very rewarding experience. I'll talk more about that maybe during the Q&A. And then very quickly at UNC, we have the Carolina Health Informatics program that I'm the associate director for. And this is a PhD granting entity, actually PhD and master's in health informatics. And the way it's set up, it's, as you know, informatics is an interdisciplinary field. So we have 9 academic units that are involved in the composition of chip. And you could see them here, health affairs, information science, the library, data science, computer science, and the rest. And this is, this kind of a setup is not only unique at UNC. There's other schools across the country that have a similar structure. But the reason why this is, in my opinion, a successful model is it provides trainees with the opportunity to learn and hear from informaticians across these schools. You can hear from the highly technical, building machine learning models and improving and working on bias and AI models, all the way to public health informatics and people in clinics or in communities trying to improve breast cancer screening using a mobile application and everything in between. And so having that exposure to different schools is an enriching experience in itself. So, for example, like at UNC, we're looking more at like, how do we train the future workforce? As you know, in doing a PhD, you start a project and you graduate in 5 years, but with the pace that things are at, you could be out of the market by the time you graduate if you don't carefully pick your research projects. And also make sure that it's translational. It just doesn't live in manuscripts and publications, which are great, but is also being translated into practice, into the communities. And so, some of the things we are known for, human-centered design, the data science, we have a strong, robust data science school. AI, like Roman mentioned earlier, is everywhere now. So everyone's talking about AI and involving it in their research, along with human factors and human-computer interaction. So I want to stop here, and hopefully this was a good overview. Happy to take questions, but I'll turn it back to Alexis to take us from there. Thank you.
Thank you so much, Dr. Kirat. And I think we'll transition now to the Q&A session. One of the other moderators, Nick, I believe, will be helping me out. But I could start with the first question. We have some that were pre-submitted from those that registered in advance. So I'll start off with, I guess if each of you could just speak on what was your first interest or motivation for getting involved within the field of clinical informatics, if there was one spark or one moment.
So for me, the moment was I was always interested in computers, though had no desire to be a computer programmer or computer scientist. And when I found out there was a field that allowed it to apply to my medical training, because I was, a medical resident at the point, this is what I want to do. And like many people, and I can't speak for Roman, I fell into it by accident because discovering the field existed and had training, which is a common thing for applicants for fellowships.
Yeah, similar experience, although it's a little different. I was in my master's training in computer science, built a computer provider order entry system, and then for a consulting company for 2 years, built the front end, the back end, was supposed to be deployed at a hospital in Canada, never went anywhere. And the reason why, I designed the whole thing from my perspective, from a computer scientist. And so it didn't really match the workflow in the hospital. Big lesson learned for me. Decided to go back to do my PhD, learned about informatics, and was really interested in user-centered design and human factors, and that struck my interest.
For me, I can localize it to like two very specific moments. Like one for me was when I was during my residency, I was working at a clinic that was a free clinic in Chicago, and we could give out medications to our patients. But we could only give out 6 weeks at a time. So I saw a group of patients. I saw one patient I remember, and then 6 weeks later, I saw the patient again, and I was writing out the exact same meds. And then 6 weeks later, I saw them again, and I was writing out the exact same meds. And I thought to myself, a computer could do this job. And then I realized, a computer really could do this job. And then thinking about it a little more, I realized a computer could actually do this better than I could. And so that's the moment that it really triggered in my head that, wow, we really are not utilizing these tools evenly. And, at my academic site, we had an electronic health record that was full service and doing everything. Northwestern was a little bit ahead of the curve, but in this clinic, we had nothing. It was all on paper. And so it was very interesting to see how that sort of aligned with some of the disparities and other things that are out there. And then during my training in fellowship, I was trying to decide between a career in research and a career in informatics. And I asked myself this question of, do you like building the thing or do you like studying the thing? And so that's when, for me, that was a sort of really important moment. And that's absolutely no shade on the people who love the researching of the thing. I think that's really, really important. But I just realized for me personally, like I was thinking I would partner with people like that rather than be somebody like that.
Great. Thank you so much for each answering that question. Would you like to ask a question, Nick? Mhm.
Yeah, so we have a question here from one of our attendees. The question is, what would you suggest for a third-year medical student who wants to learn more about the field? It sounds cool how you can make a systemic change, but I don't know if it's for me.
I, I, I would start off by saying I think many med schools, not all, will do an elective in either medical informatics or clinical informatics. I would stress clinical because unless you picture yourself as a med student going into research and you want a research project, etc., it's going to be hard to find a research team that's going to let you follow them around. When I was at Yale in a national NLM training program, which was a research program, so it may not make total sense how I got in CI, but they found it very difficult what to do with med students. But we have electives. I'm sure Rumman does. I'm sure there are electives at University of North Carolina, the medical school. The elective would be your first thing because as fellowship program directors, we look to see what's your track record. Where did you show your interest? What did you learn? But don't think you're going to start building all sorts of programs and redesigning the EHR from scratch. We've had that too. I'm a PhD, I can program. No, you can't take $100 million system and start rewriting it. Okay, that's all I have to say.
Thank you. I guess we'll go to the next question if you don't mind. How did you develop your informatics skill sets early on in order to prepare for a career within bioinformatics, biomedical informatics, clinical informatics as a whole?
I I took advantage of everything in the fellowship had to offer. I took additional courses that were up in Boston. I read, and read. I would say my prior to fellowship career prepared some interest and some broad hardware troubleshooting, but I don't think I built up my skills that way.
I echo most of these comments. Lots of reading, being open to opportunities. So I was at AMIA one time. I was fascinated by one of the presentations. Went up to the speaker, asked if I could help with this project. I didn't know who he was. It was, I think, my first AMIA. Turns out it was Charlie Safran, who is very well known in the field. and went to Boston, did some work, learned a lot, but also was very open, had a curious mind. I did natural language processing, bioinformatics, things that I wasn't necessarily so passionate about, but I wanted to learn so I could communicate back to Ramon's point, to be able to communicate this in any setting. I'm not necessarily a bioinformatician, but I'm able to understand if I'm sitting in this in a conversation or a discussion and contribute. So lots of reading, but being very curious, I'd say is good. Yeah.
It's a small community and people will help you. I mean, Charlie Safran's one of the greats and well known, and he will help you. I mean, people like that will just, sure, what can I do?
Yeah. Don't be shy. Go and speak to people.
Yeah, the one thing I'll add is that it is pretty useful. Like, like if you do research projects with someone who's doing clinical research and you have the opportunity to like play around with Python or Stata or R, that's often a way to get your feet wet with understanding like what those tools are like. And I think that it's often difficult especially as a student to be like actually changing the electronic health record, but I think that it's useful to at least understand how the data flows and how it works. And then you can often pair with someone who has done that kind of work and help them look at a clinical question that's come up based on like, oh, this EHR was changed in this way. I wonder if it changed provider behavior or if it changed patient outcomes in this other way. I'll give you a really simple example of that. Like we had a shortage nationally of blood culture bottles just last year. And it was sudden and it was widespread. And we were asked to very quickly implement a program where you could not order two blood cultures at the same time. And we had to take the blood culture orders out of some of the order sets where they existed so that people would stop ordering so many blood cultures so we could preserve the bottles that we had. And so we implemented all these changes, like 4 changes I think we implemented at the same time. So now we're doing a research project to look to see, well, which of those actually led to the most reduction and which ones led to the most unintended side effects. Like, one example for those of you who are interested in ID, I'm sure, is that if you don't order 2 blood cultures and then the one blood culture you have is positive, well, there's actually a known and relatively high false positive rate because as you're getting the blood culture, maybe as you're going through the skin, maybe you pick up some of the bacteria that live on it. And so one of the things you can look at is, well, how often did you then have to have a delay in discharge because you had to redraw a culture with a spurious commensal organism that was just living on the skin?
Great, great. Thank you for your insightful answers. I'll start off another question. I don't see that we have any in the Q&A for now. Um, do you, how do you find your niche in a field that is ever changing?
I I think your environment where you're doing informatics really determines it. It's like a scientific paper. If you ever read the methods or background, the environment really determines the experiment. Um, I think it depends on what the institution wants, what the institution thinks informatics is, what they're looking for, whether you want to be operational CI focused, or I think Saif gave an excellent talk on you want to be pure academics. I found my niche in 2 ways. I decided I was taking the third pathway. I was straddling academics and operational. Not to the degree I wouldn't be qualified to be a faculty member in Saif's department, but enough that, I published 75 papers and enough that the operational people say I'm not operational enough and the academics say I'm too operational. But and workflow determined my first big informatics projects, my first 3 or 4 papers, what I saw in process, what I saw as an attending. I do want to add, if we have time left over, I have 3 really good slides on AMIA that I held in abeyance. I just want to show them at the end. That's it.
Yeah, just to comment on that. Well, I don't know if you wouldn't qualify to be faculty. You would, most definitely. So, your needs assessment paper is something that I shared with my class a few days ago, from a few years back. So it's still landmark. So your contribution to the field, much appreciated and respected and
Thank
recognized,
you.
Joseph. I would also add to that answer. You don't want to sell yourself to things that are um, will become obsolete very quickly. The trends. Don't follow the trends necessarily. Follow the things that will remain. People will always want good healthcare, good access to health services and healthcare. There are dominant problems that we have in our healthcare system that will probably not go away anytime soon. You probably want to anchor your work in one or two of those, to make sure that by the time you graduate, you're not out of business. You still have something. But some of the people who did clinical decision support 20 years ago are still doing the same work. So there are things that will always remain hot and relevant.
I just want to emphasize two things he said. One is it's one of the reasons I think it's good to continue to practice because they'll always need doctors if you're in CI. But the more important thing is don't follow the trends in technology and jump on it because it's hot, because it's the latest in the field. The classic example is after 9/11, every grant from the federal government was on bioterrorism and something related to that. And some of the greats in the field, I sat there laughing, were rewriting grant proposals of stuff they were doing for 30 years and trying to say how it related to bioterrorism. As I predicted back then, it dried up within 3 years. He's what Dr. Want to pronounce it right, Kairat said is so important. I mean, it's what's kept people like me alive. I'm CDS now these days, usability, but I'm now bringing AI into it. I'm not saying AI is my focus.
Yeah, I would definitely echo what both Joseph and Dr. Kairat and Saf have said, which is that there's a lot of value to thinking about what the needs are of the patient and not just like what the specific tools that you have available to you. Because today it's decision support, tomorrow it's machine learning, the day after that it's like support vector machines, and then later it's artificial intelligence, LLMs, and then who knows what it'll be in 5 years. But what's not going to change is the fact that patients are sick. They're having a heart attack. They're having a stroke. They're having some, cancer. You're trying to detect it. You're trying to treat it. And so the tools should be in the service of those ends and not, the tools themselves will continue to evolve. They've evolved in our careers. They'll evolve over your careers. And you will thank yourself if you think very broadly about like how to apply these sort of principles of informatics. If you do the fellowship, or even if you study a little bit in this space, some of the principles of it will become really obvious very quickly. Like there's a great paper from David Bates at Harvard about the 10 commandments of decision support, still totally fresh. I read it when I was a resident, and it still very much reverberates through how we use the electronic health record today. Things like don't make the clinician go to a different window. Don't make them break their workflow. Make sure you redirect them rather than just telling them to stop. There's all these like things that he said, and all of those things still very much apply. So I think that it's just an example of how those insights will remain fresh.
Yeah, I mean, I'm giving a lecture in a week or two locally on AI and CDS. Half the lecture is on standard CDS principles. And I use the paper that Roman referred to. I use it every time I do the CDS rotation. If you understand basic things of workflow, that if you're going to make a doctor do something, you're giving them something back. you'll have better success than, gee, I can make the computer screen, blink red and yellow 5 times a day. That's not going to do it.
Great. Thank you all for your answers. I think that probably will wrap up the Q&A. If you'd like to share those 3 slides you mentioned, Dr.
I've got
Koenreich.
it queued up, so
Yeah,
I'll
you're
do this
welcome
really quick.
to find those.
Would probably like to get out of here.
Yeah, I was going to ask about like where you think the field of clinical informatics is going, but you guys naturally answered it. So thank you all. You read my mind.
So these are slides from AMIA. I'm not recruiting for them, but these are reasons to join AMIA. They have student memberships that are very affordably priced. It's like about 1/7 or 1/6 of what the normal course is, like $75. The annual symposium, Saif mentioned it, I've mentioned it, go. You really want to see it, go. And basically, what's going to decide your attendance is geography. This year it's Atlanta, next year it's Dallas, and I think the year after it's San Diego. This is Amy's self-description, but it's correct. It's probably closer to 3,000 attendees.
Are you sharing your screen right now? No.
Oh, sorry.
Click share. Sorry about
All
that.
the time at work too. 1 second. I thought I was, but apparently I didn't press the share button. Okay. Do you see it now?
Yes, I can see it. Thank you.
I'm just going to flip through the slides because I spoke to them already. One more. Okay. That's it. That's probably it. But I would just seriously consider being a student member of AMIA.
Great. Thank you so much. It's really great.
You're welcome.
Alrighty. Well, we wanted to thank our wonderful panelists for their insightful comments and for our attendees for joining us for this event. A huge shout out to our panelists, and we are incredibly grateful that you made time to offer us your experience and wisdom. And we did want to bring up our next APSA event, which will be next Thursday, October 9th, and it will be all about strategies for making your residency rank list, as well as other tips and tricks for PSDPs beyond the interview. Registration information is on our website, and we hope you can join us. We are going to be putting the link to the APSA interactive sessions in the webinar chat. Let me just put that there. So this link will take us to the ABSA website, and it will have the event I just mentioned next week, but also rather on October 9th, and also all our other upcoming events. So with that, I don't see any more questions in the Q&A, and I'd like to thank our panelists once again, Alexis, for putting this all together and for moderating, and for our attendees for joining. Thank you all.
Thank you for having
Great.
us.
Thank you.